As the fourth speaker in this debate on health information technology is already improving healthcare safety and current regulation around it is sufficient, and taking the opposing view, I'll try and sum up what has been discussed by our group and also bring perhaps my perspective onto how this has worked. I'm Guy Madden. I'm a general surgeon with an interest in hepatobiliary surgery. I'm a practicing clinician and operate and see patients on a daily basis. The topic is, of course, of great interest to me in that as a clinician, I'm constantly having to wrestle with the realities of dealing with IT systems and the electronic health record that is now being expected of us throughout the health system. I currently work in Australia and am the Professor of Surgery at the University of Adelaide, which is in South Australia, and have had an interest not only, of course, in clinical practice, but also have been involved in health technology assessment over many years. This phenomenon of health technology assessment is looking at various processes, devices, procedures, or what may be available, and then assessing whether or not the evidence supports it, where the evidence is sufficient, and gaining further evidence if it's needed. So therefore, information technology systems fit very well into this. There has been great enthusiasm for electronic information systems. This has been driven in part by individuals who believe this is the way forward, and also heavily pushed by companies who believe that they can make substantial profits from filling a void that currently exists. At present, many hospital systems, certainly outside of North America, are still using paper-based systems. One has to ask oneself why this is the case, given that we are all very used to having smartphones, computers in our offices and at our homes, navigation systems in our cars. Why is it that the health sector has been so slow really to embrace the electronic health record and its enormous promise that it brings? Huge companies with enormous capitalization have invested billions of dollars into trying to develop an electronic health record and information technology system that delivers what the physicians need. The difficulty has been, I think, largely that these systems have been developed by computer geniuses without much reference to the doctors, nurses, allied health professionals that are going to have to work with the technology that is made available. For this reason, the capabilities of many of these systems is extraordinary, but the usability is anything but remarkable. As I mentioned, I work in Australia, and we have introduced into this country a patient-controlled electronic health record. This was brought in with great fanfare and great promise. It has had already almost $1 billion spent on developing and rolling it out. There are apparently some million people or more enrolled in the patient-controlled electronic health record, which sounds like a great success in a population of only 20 million and a relatively short period of introduction. The difficulty has been, of course, with this, that although people have enrolled, the number of active records is counted in the tens of thousands rather than in the hundreds of thousands or millions. The problem has been engaging the clinicians, the patients, the hospitals, and the diagnostic facilities into providing data into these systems. The regulation around these systems has been unbelievably complicated and has led to great concerns for many of the practitioners in using it. There was tremendous support for the general practitioner, the local doctor, becoming linked into this, but there was no support provided or particular impetus given to specialists who may want to use such a system. As a result, the general practitioner's records are potentially made available within the patient-controlled electronic health record, but specialist and hospital engagement is largely missing. In a country like Australia, where particularly as people get older, they travel quite large distances, the ability to have a portable record is obvious. The reality, however, is that this is largely unused, and indeed, I would have to say in my own hospital, I would not be certain I have any idea how we would access it, despite the fact that I know it's available. In any case, the number of individuals who have chosen to take it up is so small as to make it largely useless. Even if it is provided, the ability to know how complete it is and to control whether it's had any unhelpful information provided is difficult and always fraught. For that reason, many people have elected not to go down this path, but to resort to the age-old solution of actually asking the patient, taking the history and knowing that it is in a one-to-one environment. One of the concerns of the patient-controlled electronic health record was that information may indeed be inaccurate. This, however, of course, is not unique to electronic health records. Patients themselves can provide information that is, in fact, not completely truthful. Some patients will withhold medications they're on, illnesses they've had, and procedures they've undergone. For this reason, we always live with an imperfect medical record, no matter whether it's electronic or patient-generated. Nonetheless, it does help when the physician, surgeon, general practitioner has the confidence that the information they're getting is likely to be complete and reliable, and this is unfortunately often obtained best from direct interaction with the patient, albeit cumbersome and potentially unreliable, particularly as patients get older, their memories fade, or they become confused and demented. A reliable electronic health record is valuable, but it needs to be updated and maintained in a predictable fashion, something that we have not yet been able to experience in Australia. The other issue that needs to be considered is the hospital-based electronic health records and the regulation that goes around them. Largely, the regulation is missing. The records are generated by private providers, individual hospitals or regions decide to adopt them, and they are rolled out within a health system or hospital or region. The regulation has not been keeping up with the technology. Access to these electronic records is potentially open to those able to look at and manipulate the computer systems. It is true, of course, the availability and access of a paper-controlled record is probably little different insofar as they often lie in patient areas, and individuals determined to gain access to them probably can relatively easily. I think the big difference that needs to be understood between an electronic system and a paper-based system is that the paper system, one can only imagine invasion of it on a relatively infrequent basis relating to a handful of patients. It is, however, quite possible with an electronic health record, depending on how it's been constructed, to look at an enormous number of records and actually trawl for certain conditions or certain individuals or types of individuals, and then provide information about them, to them, which may be considered highly confidential and personal. The regulation has not really kept a pace with this, and the need to understand the capabilities of an electronic health record and how it could be misused is largely not discussed. This is partly, of course, because individual hospitals and health services are keen to have a digitized data system without really thinking through how it can be abused. We know already that computer systems can be hacked at the highest levels around the world, and given the availability and the large number of individuals who need access to an electronic health record, the possibility of gaining access to and abusing that privilege is certainly considerable, and regulation is absolutely essential if we are going to maintain a sensible control on what we have generated. The other problem is the specifications around the electronic health record. Radiology has developed a number of clear specifications around the electronic system that presents imaging for assessment by radiologists. This requires careful thought about the quality of the image, the way it can be accessed, the speed with which it's accessed, and how it is presented to the user. Very little such thought has gone into most electronic health records. They are designed by individuals who often do not have to manage patient problems, and as a result of that, they have not thought through all of the important clinical issues that need to be presented. They often present the data with an equal weight. For example, the result, an abnormal pathology result, which might be of great importance, is treated little differently than the temperature or the respiratory rate that may also be recorded by the nursing staff. It is important that these things be calibrated and that importance be given to the essential items that will make life and death decisions on, rather than just a general dump of an enormous amount of data about patients. The problems of electronic health records, however, are greater than just the potential for hacking and downloading of information. The big problem with an electronic health record and the information systems we're currently using is they're isolating us from our patients. While I can certainly not touch type, when I use an electronic health record, I often find myself staring at the computer screen rather than actually talking and observing the patient and their family. This can often be of enormous frustration to patients. It's enormously frustrating to me, and the result of the interaction is often less than satisfactory. I have to say I've resorted now to taking brief paper notes, and when the patient has left, entering a fuller and complete record of the consultation. This adds time, money, and expense to the process, and is, I think, something that needs to be addressed if we are to have a truly interactive electronic health record that engages the patient rather than isolates them. The regulation around this needs to be thought through. We need to ensure that patients are not finding themselves isolated by being subjected to an electronic process. So I think we've heard from Ross some of the more technical issues regarding the regulation problems. I feel that as a clinician, the problems are very personal and very much related to having high quality care of patients. Many of the records have been developed for accounting reasons rather than patient care reasons, and the outcomes are measured in billing success rather than patient treatment. There is no doubt that having access to thousands and thousands of medical records provides an unbelievable research tool. But until we understand how this can be managed, how it can be protected from abuse, and how it cannot, in fact, disadvantage the doctor-patient relationship, it may be a price too great to pay. Regulation is needed. Better understanding is needed. No doubt the next decade will see these technologies become more widespread, but at the moment they are at best primitive, unhelpful, and poorly developed. I think our team has made a compelling case. I don't think there is any doubt that the regulatory environment in which we are currently placed is inadequate and needs a lot more thought and a lot more imagination.